Hello friends, today we are going to discuss about acute exacerbation of COPD. An exacerbation is defined as an event characterized by the increased dyspnea sputum cough that worsen in less than 14 days, which may be accompanied by tachypnea tachycardia and is often associated with the increased local and systemic inflammation caused by infection, pollution and other systemic insult to airway. So regarding pathophysiology, chronic obstructive pulmonary disease patients have resting expiratory flow limitation due to airway inflammation and narrowing that lead to insufficient time to expiration and lead to the airway air trap. So end expiratory lung volume fluctuates widely and are influenced by expiratory flow limitation and ventilatory demand. During exercise and any situation of increased demand, as inspired tidal volume increases, expiratory flow limitation causes increase in end expiratory lung volume from baseline, which leads to a dynamic hyperinflation. So during acute exacerbation of COPD, there is abrupt narrowing and inflammation of airway, which leads to the increase in end expiratory tidal volume and dynamic hyperinflation. Due to presence of dynamic hyperinflation, compliance of lung will reduce, which limit tidal volume despite increasing the inspiratory effort. Patient become tachypneic and adopts rapid shallow breathing pattern, which further worsens the dynamic hyperinflation. Due to expiratory flow limitation and dynamic hyperinflation, intrapulmonary pressure remains positive even at the end of expiration, and it is termed as autopy. This acts as inspiratory load, which further increases the work of breathing. Now, the risk factor for acute exacerbation of COPD: history of prior exacerbation, history of hospitalization for prior exacerbation of COPD, elderly, duration of underlying COPD, mucus hypersecretion, presence of other comorbidities such as cardiac disease, diabetes mellitus, and pulmonary hypertension. Infectious etiology for acute exacerbation of COPD is viral infection like rhinovirus, respiratory syncytial virus, influenza virus, parainfluenza virus, coronavirus. Then bacterial infections like H. influenza, Moraxella, Streptococcus pneumoniae. So exacerbation can be triggered by viral and bacterial infection. Environmental factor like air pollution and excess heat may also amplify this event. Short-term exposure to fine and coarse particulate matter and nitrous oxide can also aggravate these conditions. Some viral infections are also responsible for these conditions. Viral infections like human rhinovirus, influenza virus, parainfluenza virus, metapneumovirus can identified in this condition. When due to viral etiology, infections are more severe and last long. Filamentous fungus, particularly Aspergillus, may be identified in sputum sample of the patient during moderate to severe exacerbation. Invasive pulmonary aspergillosis is rare and more frequent in patients with severe airflow obstruction. Recent use of antibiotics, steroid, and hypoalbuminemia. Aspergillus sensitization is also marker of increased risk of exacerbation. If sputum is purulent, it is more likely due to bacterial infection. Presence of sputum eosinophilia is associated with viral infection. Increase in sputum and blood eosinophils may be responsive to steroids. Other factors associated with increased risk of exacerbation and severity exacerbation include increase in pulmonary artery to aorta cross-sectional dimension. That is, if it is more than 1, there is a greater percentage of emphysema or air wall thickness measured by CT imaging. Exacerbation may be associated with severe vitamin D deficiency. Now, regarding diagnosis and assessment, complete thorough clinical assessment for COPD and potential respiratory and non-respiratory disease, concomitant disease, including consideration of alternative causes like pneumonia, heart failure, and pulmonary embolism. So after the diagnosis is to confirm, the our job is to our job is to assess the patient for severity based on symptoms, signs, and investigations. So we will the investigation which are required for the evaluation of the patient with the COPD is full blood count, serum biochemistry, ABG, pulmonary function test, CRP, PCT, chest X-ray, ECG, echocardiography, troponin, proBNP, and CT scan. And based on the our PFT, the severity of the pulmonary COPD is divided into four classification. That is, if mild, if FEV1 is more than 80%, if moderate, if FEV1 is greater than 50% but less than 80%, severe if FEV1 is more than 30% but less than 50%, and very severe if FEV1 is less than 30%. Then the next score which can be used for the severity assessment is the DECAF score, that which include dyspnea, eosinophil count, consolidation, acidosis, and atrial fibrillation. Total DECAF score is 6. Now, the severity can be determined easily by obtaining dyspnea intensity using the visual analog intensity, which is graded from the 0 to 10. 0 means no shortness of breath at all. 10 means severe shortness of breath. And other parameters are heart rate, respiratory rate, and saturation level. So investigations like CRP and ABG are needed to determine the severity. So COPD patient with suspected exacerbation is divided into mild, moderate, and severe. So mild means the visual analog score less than 5, respiratory rate less than 24, heart rate less than 95, resting SpO2 more than 95, and CRP less than 10. Moderate means visual analog score more than or equal to 5, RR more than or equal to 24, heart rate more than or equal to 95, resting SaO2 less than 95, breathing and ambient air, then CRP more than or equal to 10. If obtained, ABG may show hypoxia and hypercapnia but no acidosis. Then severe includes dyspnea, RR, heart rate, SaO2, CRP same as moderate, but ABG shows new onset worsening hypercapnia and acidosis. So we can consider the differential diagnosis as heart failure, pneumonia, and pulmonary embolism. So based on this, we will divide the patient into three categories, like no respiratory failure, acute respiratory failure, and life-threatening respiratory failure. And the treatment is divided into pharmacological treatment and respiratory support. Now, pharmacological treatment is the first one is bronchodilation. It is recommended that short-acting beta-2 agonist with or without short-acting anticholinergic are initial bronchodilator for treatment of COPD. So short-acting beta agonists include albuterol and the levoalbuterol, and these drugs are selective beta-2 receptor agonists that induces smooth muscle relaxation and the relief of bronchospasm. They can be administered via inhaler and by nebulizer. Common side effects include tremor, tachycardia, and hypokalemia. Now, the next treatment of line is anticholinergic. Short-acting anticholinergics are ipratropium bromide, which block muscarinic acetylcholine receptor, thus promoting smooth muscle relaxation and inhibition of mucus secretion. These medications improve lung function and partial pressure of arterial outflow. Common side effects include dry mouth, nausea, tachycardia, and sedation. There is concern about nebulized anticholinergic, which may precipitate worsening glaucoma by coming into contact with the eyes in susceptible individuals. In general, we use combination of nebulized short-acting beta agonist and anticholinergics. Now, the next pharmacological treatment is corticosteroid. Corticosteroids are routinely used for treatment of COPD exacerbation. It shortens the recovery time and improves the lung function. The recommended dose is 40 mg per day for 5 days. The longer course of corticosteroid is associated with increased risk of pneumonia and mortality. Therapy with oral prednisolone is as effective as IV administration. And nebulized budesonide alone may be suitable alternative and may provide similar benefit like intravenous methylprednisolone. Even short burst of therapy is associated with increased risk of pneumonia, sepsis, and death. So use should be confined to patients with significant exacerbation. Corticosteroids are less effective in patients with the lower levels of the eosinophils. Now the next is antibiotics. Antibiotics are intervention that is of proven benefit in acute exacerbation of COPD in ICU admission. One must take into account potential pathogen, local resistant pattern, and antibiotic stewardship. The most common bacterial pathogens are Haemophilus influenza, followed by Streptococcus pneumoniae, Moraxella catarrhalis, and Pseudomonas aeruginosa. And some viral pathogens are rhinovirus, influenza virus, and respiratory syncytial virus. So regarding antiviral, viral infection, in particular rhinovirus, which accounts for 30% of COPD exacerbation, and variety of potential therapeutic agents have been investigated. Unfortunately, although neuraminidase inhibitors such as oseltamivir and zanamivir are effective against influenza, and antirhinoviral medication have failed to demonstrate a clinically significant benefit. So we do not routinely test for viral exacerbation outside the influenza season. Now regarding antibiotic, there is evidence in supporting the use of antibiotic when patient has a clinical signs of infection like increase in sputum purulence. So antibiotic should be given to patient with exacerbation of COPD with three cardinal symptoms, that is increase in dyspnea, sputum volume, sputum purulence, or have at least two of the cardinal symptoms. The recommended length of antibiotic is 5 to 7 days. The choice of antibiotic is depend upon the local resistance. Usual initial empirical antibiotic therapy is aminopenicillin and clavulanic acid, macrolides for a typical coverage, tetracycline, and in selected cases, quinol. In patient with the frequent exacerbation, severe airflow obstruction, and patient requiring mechanical ventilation, we need to send sputum culture because of high risk of MDR pathogen. Now, the route of administration is depend upon the pharmacokinetics and patient ability to eat. Now, regarding adjunct therapy, depending upon the condition of the patient, appropriate fluid balance, use of diuretics when clinically indicated. Anticoagulants, treatment of comorbidities, and nutritional aspects should be considered. Among patients who are admitted with exacerbation, 5.9% were found to have pulmonary embolism. And hospitalized patients with COPD have increased risk of deep vein thrombosis and pulmonary embolism. Now, respiratory therapy is oxygen therapy. Supplemental oxygen should be titrated to improve patient hypoxemia to target patient's oxygen saturation between 88% to 92%. So once oxygenation is started, blood gas should be obtained frequently to ensure oxygen concentration, CO2 retention, and worsening acidosis. So the VBG is more accurate than ABG in demonstrating pH and bicarbonate levels. Avoidance of hyperoxemia is important because of well-described occurrence of worsening hypercapnia. There is evidence to show the indiscriminate use of oxygen therapy increases mortality and need of intubation. Induction of hypercapnia through hyperoxemia is still poorly understood. And it is thought to be the combination of mostly change in mismatch with mild decrease in central respiratory drive and Held. The ability of the lung to shut blood away from areas of low alveolar oxygen tension is disrupted by administration of high level of oxygen. The resultant change in matching leads to the increased rate space. The Heldon effect describes the binding ability of hemoglobin for CO2 as increased oxygen shifts the hemoglobin CO2 dissociation curve to right and leads to the increase in partial pressure of arterial CO2. Now the next modality is high flow nasal oxygenation. High flow nasal therapy delivers heated and humidified air oxygen blend via special device at the rate of up to 8 liter per minute in infant and 60 liter per minute in adult. High flow nasal cannula is associated with decreased respiratory rate, effort, decreased work of breathing, improved gas exchange, lung volume, dynamic compliance, transpulmonary pressure, and homogeneity. So high flow nasal cannula improve oxygenation and ventilation, decreases hypercarbia, health related quality of life in exacerbation, and stable COPD patient. It did not prevent the rate of intubation. Now, ventilatory support is in the context of exacerbation can be provided in the form of non-invasive ventilation and invasive ventilation. So, indication for non-invasive mechanical ventilation is respiratory acidosis, that is pH less than 7.32, 35, PCO2 more than 60. Severe dyspnea with the clinical signs suggestive of respiratory muscle fatigue, increased work of breathing or both, such as use of respiratory accessory muscle, paradoxical motion of abdomen or retraction of intercostal spaces, persistent hypoxemia despite supplemental oxygen therapy. Then indication of invasive mechanical ventilation is unable to tolerate NIV or NIV failure, status post-respiratory cardiac arrest, diminished consciousness and psychomotor agitation, inadequately controlled by sedation, massive aspiration and persistent vomiting, persistent inability to remove respiratory secretion, severe hemodynamic instability without response to fluids and vasoactive drug, severe ventricular and supraventricular arrhythmias, life-threatening hypoxemia and patient unable to tolerate NIV. Now, regarding ventilatory setting in COPD, we can use volume assist control or pressure assist control. Tidal volume as like 6 to 8 ml per kg of predicted body weight. Initial respiratory rate is 10 to 12 per breaths per minute. PEEP initially 0 when patient is paralyzed or ventilated. Later, once patient start breathing spontaneously, we can start with 5 and later titrate it to approximately 80% of auto PEEP. FR2 is titrated to 80 to 90%. Short inspiratory time to high peak flow, that is 60 to 90 liter per minute. Prolong inspiration to expiration ratio, that is 1:4 or more, while checking that expiration is complete. By reducing set respiratory rate, inspiratory time, and increasing the peak expiratory flow rate, the absolute expiratory time is increased, preventing development or worsening of autopsy. Currently, setting very high flow rate are not advisable and are suggested to cause ventilator-induced lung injury. Treatment of autopsy include optimal medical treatment for airflow limitation, adjusting ventilatory setting, thereby allowing enough expected time by reducing respiratory rate, decreasing tidal volume. The patient's ventilatory requirement can be reduced by treating anxiety, pain, and fever. The use of endotracheal tube with large internal diameter and clearing secretion from endotracheal tube will also help to reduce flow resistance. In case of acute severe airflow obstruction leading to autopsy, patient will require sedation and paralysis. Now the next is waterfall effect. The autopsy that occurs in patient with airflow limitation is the direct result of critical closure of the airways. The physiology of critical closure of airways have been elegantly explained by analogy of the waterfall, where height of the waterfall reflects the magnitude of critical closing air pressure. One of the most characteristic and peculiar feature of this phenomenon is the fact that elevating pressure downstream from the site of critical closure has no influence on either flow and pressure upstream from the site of critical closure. This situation exists up until the downstream pressure is elevated to value equal to the critical closing pressure. Once the downstream pressure is elevated to value above critical closing pressure, the pressure upstream is immediately increased and hyperinflation is exacerbated. Thus, the presence of auto PEEP, external PEEP should not impede the expiratory flow and causing hyperinflation as long as its value is no higher than critical closing pressure. We term this the critical level of external peak. Another consequences of waterfall concept is that external PPs increase from zero up until the critical level. There is progressive apparent decrease in calculated expiratory resistance. However, this is the spurious decrease because pressure downstream from waterfall is not true back pressure from the flow over the waterfall. So this is the pictorial representation of the waterfall phenomenon. So first diagram is there is a auto pip of 10, and when the external pip is 0, that means this so it is shown that the upstream pressure is higher than the downstream pressure. So when the second picture is showing the auto pip of 10, and when we apply the external pip of 10, then there is a no influence on the flow as well as on the pressure. So we should keep in mind that our applied external PEEP should not exceed the extrinsic PEEP so that it won't cause hyperinflammation and the further damage. So that's all. Thank you. Thanks a lot for paying attention.